Today's surgery lab is Small Animal Reconstructive Surgery Lab 1. This lab will focus on closure of the subcutaneous tissue layer and the skin. The objectives of this lab are to allow you to review and understand the anatomy of the skin as it pertains to basic suturing and wound closure. You should be able to identify the layers of the skin, including the epidermis, the dermis, and the subcutaneous layer, which is sometimes referred to as the hypodermal layer, at the end of this lab. This lab will also allow you to practice instrument handling skills with special focus on handling of needle holders and thumb forceps. Would like to work on soft tissue handling techniques, and you will have the opportunity to practice common basic suture patterns which are used to close the subcutaneous layer, including simple continuous or interrupted sutures with buried knots. Once the subcutaneous layer is closed, you can also practice your common basic appositional suture patterns of the skin, either simple interrupted sutures, cruciate sutures, or forward interlocking sutures. The equipment needed for this lab will be a piece of harvested canine or equine skin, which includes the subcutaneous tissue, and most of the samples will also include the cutaneous trunci muscle. This skin will be fixed to a clipboard to allow you to incise and suture. You will wear surgical gloves, and you will need a needle holder, Brown Adson thumb forceps, suture scissors to cut your sutures. These are usually sharp scissors, a number 3 scalpel handle, and a number 10 scalpel blade. When considering the anatomy of the skin, this is very important to surgeons that we understand the specific layers of the skin for not only incision depth, but also for closure. The skin is composed of 3 distinct layers. The epidermis, which is the outermost layer, very thin, usually 1 to 2 millimeters, provides accessory nerve sensation and protection for heat exchange. The epidermis is very sensitive to handling with instrumentation or even fingers, so we want to avoid surgical trauma of the epidermis. The dermis is the thicker layer immediately below the epidermis and attached by a basement membrane. The epidermis is more fibrous, and it also houses appendages of the skin such as the hair follicles, blood vessels, sensory and motor nerve fibers, and sweat glands. The subcutaneous layer is directly below the dermis. The subcutaneous layer is sometimes referred to as the hypodermis. This is a fatty layer with loose connective tissue and also will have a small amount of thin muscle, especially over the truncal region in our patients, that is referred to as the cutaneous trunci muscle or the panniculus muscle. Blood supply to the skin comes through the muscle layer and the subcutaneous layer into the dermis, so it's very important that we respect and preserve this tissue. Upon making skin incisions, we routinely cut through the epidermis, dermis, and into the subcutaneous layer. Depending on the specific patient and their body condition score, we may have more or less of this loose fatty tissue below the skin. For instance, if you consider a dog such as a Labrador, a Newfoundland, or a Golden Retriever, they tend to have a lot of body fat underneath the skin, and that subcutaneous layer may be quite thick. Other patients that are thinner or more juvenile will have a very small amount of fat. It is not uncommon to recognize in dogs that there is fat directly below the dermis. Then we see the thin muscle layer, and there will be additional fat below the subcutaneous trunci muscle and either the body wall or bony structures. We've taken a piece of canine skin and incised it, and you will notice that we're showing the fatty tissue deep, and then you will see the thin cutaneous trunci muscle, but you will also notice that there's fatty tissue between the dermis and the cutaneous trunci. Everything below the dermis is considered subcutaneous. Last, we were showing the area of the dermis with the hair follicles, and the epidermis is the outermost millimeter or two layer that the hair follicles exit. So why do we close the subcutaneous layer? There are a number of important reasons, but the first and most common reason is closure of dead space. Dead space is defined as the separation of tissue planes from either traumatic or surgically induced wounds, which ultimately create a pocket or space that will fill with fluids such as serum, blood, inflammatory, or purulent exudate. It is a separation of tissue planes. If this space is left in place, it will result in slower wound healing and can increase the risk of infection to the patient. The second most important reason of closing the subcutaneous layer is reduction of tension on the primary skin suture line. By closing the space below the skin, we will start to bring the skin edges in apposition and reduce the tension when we go to close the skin. How you place your subcutaneous closure layer will depend on how close your skin edges result in apposition. By closing the subcutaneous layer, we also provide a level of cosmetic improvement to the wound. So we want to make our closure look good. When closing the subcutaneous layer, we're going to be placing suture material completely below the skin. Therefore, we're only going to be considering the use of absorbable suture material since there's no way to remove it. It is also important that we make sure that all suture knots located below the skin edges are considered buried. The buried knot means that we'll position the suture knot so it is completely below the dermis, so it prevents it from sticking out or popping up between the skin edges, which is going to interfere with wound healing. Buried knots are performed with both interrupted and continuous suture patterns. To place a buried knot when closing the subcutaneous tissue, we're going to start at the very end of the incision, and the bites of the pattern will be placed perpendicular to the incision. So the surgeon will start with a mounted needle by placing a bite from on the near side closest to them in a forward pattern from the deepest portion of the wound, superficial so the needle exits just below the dermis. Once the needle has exited, it will be remounted, and then the surgeon will place the same type of bite on the far side of the incision, but start superficially just below the dermis with the needle exiting deeper into the subcutaneous tissue. This functionally creates a pattern that looks like an upside down U. When we tie this pattern, we will very carefully tie the knot so that our hands are always moving parallel to the incision to draw the tissue edges over top of the knot, and the knot will stay down deep in the fatty tissue of the subcutaneous. So using a simulator to show the mechanics, it's a little bit hard to place buried knots in a simulator, but as you see, we're going to part the edges, and with the needle mounted in a forward motion, we start deep, and the needle is rotated and brought, which would mimic being underneath the dermis, and exited. You'll see as the needle is exited, the thumb forceps are used to stabilize the needle, and then the needle holders are replaced to rotate around. The needle is now mounted so that we would be simulating the second bite being taken on the far side of the incision, and the needle will enter perpendicular just below the dermis, and it will exit deep. It's good to learn to try to make each side look like a mirror image so that where you start and where you end is the same on both sides. So again, we're showing we're all the way down in the pink tissue there, bringing the needle around. Now, it is very important when we're tying buried knots that the leading end of the suture with the needle and the short tail end are both heading in the same direction that you will be suturing, and you see the U-shaped portion of suture will be crossing over. So as we tie this, that U-shaped portion of the suture is going to push the knot down. So we pull the suture down, and as we get ready to tie, you're going to use basic instrument pattern, 1 loop, gently grab the suture tail, and always tie parallel to the incision, not across, parallel, and create a situation where the knot moves down. We'll tie 4th rows, make 2 square knots. Once 2 square knots are adequately tied, when we cut the suture tag, we want to make sure that we cut it nice and short because we don't want a tag to poke out from the incision. So here we are making an incision into some equine skin. You'll see it's much thicker and fattier than the dog. We're applying perpendicular tension as we incise, and we're going to go a little bit deeper and actually cut into that cutaneous trunci muscle here. So as you can see, we have nice color on this horse skin. The skin is a little bit tougher as you get prepared to suture it. Now, one thing you'll note when you're making your sub-Q incision, that the cut in the fatty layer should be the same length as the actual cut through the epidermis and the dermis. You want to make sure all tissue layers are the same. But as we start the buried knot, we go to the end of the incision, start deep, bring the needle around superficial. You notice the thumb forceps are not pinching or grasping the skin, just stabilizing it. Bring the needle through, remount the needle on the near side, and the next bite will be taken just below the dermis, just below where you can see the hair follicles. Thumb forceps are used just to hold the subcutaneous tissue out with a little tension, and the needle is brought around. The needle should not be pushed through the tissue, but use a flick of your wrist to pop it through. And again, the leading edge and the tail edge need to be heading in the direction you're going to suture, both on the same side. And you see the suture loop, looks like an upside down U, will be pulled down and the suture will be tied. Again, basic instrument tie, bringing the suture, hands always working in the same direction as the incision is made. Now, if you look carefully, the side of the incision away is the bite is up a little bit closer to the skin edge, and you see the skin edge is pulled down just a little bit because of that. So you want to try to make sure that you have mirror image bites on either side. Once we've completed the initial buried knot, we're ready to close the subcutaneous layer. Subcutaneous closures are routinely either done with a simple interrupted pattern, but each individual suture would need to be placed with a buried knot, or it can be done with a simple continuous pattern starting and ending with a buried knot. I would have to say that when I'm performing a procedure that requires that it be very cosmetic, I will often choose to do my closure interrupted because I can be very precise and very specific. It is, however, very time consuming to close all layers, especially the subcutaneous, in an interrupted pattern. So most surgeons will typically choose to do a simple continuous pattern. Now, when we consider our patients, we mentioned before that some of our patients may have a very high body condition score and a large amount of subcutaneous fat. We need to make a surgical decision based on how much fatty tissue is there and how we're going to run our continuous pattern. One thing we don't want to do is take very large bites of fatty tissue on either side as we progress down the closure. This tissue will become strangulated in the suture and then will ooze a greasy fluid that will contribute to seroma formation. We also will end up with a large area of fat protruding between our skin edges, which will not be opposed. So it's a good idea when running your simple continuous in the subcutaneous tissue to take smaller bites on either side. The skin will come into apposition depending on where you place the bites. So if the bites are placed fairly close underneath the dermis, you will have good apposition of the skin when you have completed your subcutaneous closure. The other problem you face with that is if the patient has a large amount of fat and the simple continuous is run immediately below the dermis, you will have a gaping area of dead space below. In those particular situations, we may choose to run 2 patterns of simple continuous, one deep in the fatty tissue to help close the dead space, and then one more superficial to again close dead space and help do a better job of bringing the skin edges into apposition. I would say that most patients that we work on, we can close the subcutaneous in one layer, but we just need to be prepared to make that decision on a patient-by-patient basis. Here we've made an incision in some canine skin. The buried knot has already been placed, and we're going to go ahead and run a simple continuous in the subcutaneous layer. So you see the bite is taken through the subcutaneous layer and includes a small amount of that cutaneous trunci muscle to help reoppose it. So a small amount of fat, cutaneous trunci, and then a small amount of fat between the cutaneous trunci and the dermis. You want to make sure as the suture bites are pulled that they are not pulled tight. We're just trying to bring the edges back into apposition. Now again, depending on how you place your sutures will depend on how close the skin edges will end up in apposition. You can see the thumb forceps are being used to gently control the fatty tissue and cutaneous trunci muscle to help place the suture bites without actually grabbing the skin layer, which is that epidermis is very sensitive to those thumb forceps. So we're really trying hard to avoid grabbing our skin. And again, you see as the bites are pulled down, they're brought into apposition, and you see we have a gap between the edges of the skin, but it's not really a large gap. It'll allow us plenty of room to get in there and either place skin sutures, or if we should choose, we have enough room to get in there to place intradermal sutures. If this particular patient was extremely heavy and maybe had quite a bit more fat below that cutaneous trunci muscle, as I mentioned before, one option would be to do a deep closure just below the cutaneous trunci, and then a second closure as you're seeing here with the cutaneous trunci and some of the subcutaneous fatty tissue below the dermis. As you notice the hair follicles running through the dermis, you'll see that the needle always exits well below them. We don't want to engage the dermis in our subcutaneous closure. We'll choose to close that with another pattern. We want to continue the subcutaneous suture pattern all the way through the end to the end of the incision, and then we were going to end this suture pattern with a second buried knot procedure. You'll also notice as we suture placing the simple continuous pattern that in most situations the needle is passed from one side, remounted, and passed to the other side. This is done for more accuracy. When the needle is passed directly from one side into the opposite side, we call that double dipping. And there are certain situations where that's appropriate if you have really good apposition, but you have far more control and you will develop more manual dexterity by passing the needle, stabilizing it, remounting, passing the needle again as you learn to suture. Now, as we get to the end of the suture pattern, of the suture line, you'll notice that we're taking a perpendicular bite on the far side, and this will get us ready to start our final buried knot. So we have a perpendicular bite from superficial to deep. To end our subcutaneous closure, we need to place a buried knot. And we're going to start this procedure about 1 centimeter from the end of the incision. We want to make sure we get pretty close to the end because we don't want a gaping opening at the end of our incision if we start it too soon. To start the procedure, as you saw in the last suturing video, we took our last bite perpendicular on the far side from superficial to deep. And the reason we do that is to get a buried knot, we have to get our suture starting from a deep position. So to actually begin the buried knot procedure, we're going to mount the needle and take a bite perpendicular to the incision edge, coming towards the surgeon on the near side from deep to superficial. We want the needle to exit just below the dermis, so we're in the subcutaneous, and we won't pull that suture loop all the way through, but we'll go ahead and use a hemostat or our suture scissors to help hold that suture loop out of the way. The final bite is taken at the very end of the incision on the far side from the surgeon, and the needle is oriented from superficial to deep. So the needle will actually exit and come up through the incision very close to the base of the loop that we just made and held from our second to last suture. Once we do this, we've created what we call the elephant appearance. We have 2 loops and a trunk. We're going to go ahead and pull the last loop down. That helps close the end of the incision, and tie to the loop that we've retained with our scissors or our hemostat. Again, remember when you tie that we're always going to move our hands in the same direction as the incision, which will allow the knot to go down and the tissues to come over top of it. Okay, so we've now closed our subcutaneous. The suture is deep, so we're going to come from deep to superficial, and we're coming towards the surgeon, and we're going to retain this loop with an instrument. Our last bite will go on the opposite side, generally away from the surgeon, and it is going to go toward the end of this incision from superficial to deep, so the actual needle will come up close to the base of the loop that was just made. So this will create a second loop, which is part of the elephant, but pulling this suture loop down will close off the very end of the incision for us. So we have 2 ears and a trunk. I'm going to remove my thumb forceps, pull the second ear down, and we're going to tie to the first ear. Remember, always tying parallel to the incision. And as we have a loop knot in your needle holder jaws, as you pull, just gently open the jaws of the needle holder to allow that knot to tighten down. Open the jaws, tighten it down. And again, this is the subcutaneous layer, so the skin edges are still moving apart. We're going to go ahead and cut the loop end very short because we don't want tags sticking up. And as you see, the subcutaneous layer is closed and the skin edges are in apposition. Following the closure of your subcutaneous layer, you can go ahead and practice any of the appositional suture patterns that we practiced in the previous lab: simple interrupted, cruciate, simple continuous, or forward interlocking. You've been supplied with some non-absorbable suture on a cutting needle to use for the skin closure. I'd like you to work on tissue handling. We'll work on knot tying and making sure that your sutures are not too tight or too loose. In the last segment of suturing here, I've just demonstrated 3 of the 4 patterns, and you can do any or all of them that you would like.